Well, thank you, and thank you for coming. I'm Dr. Kurt Possai. I work at Grand Itasca Clinic and Hospital. For those who know me or don't know me, I actually moved from Thief River Falls, Minnesota about a little over a year ago to come here. My wife and I, we moved up there about 16 years ago where we raised our family, our 2 kids. So our kids are a bit grown now, and about a year ago we moved here. I grew up really on the East Coast area, more around New York and Pennsylvania, nice areas. So Western New York. I did live in New York City for a year. That's where I did my internship. Moved out to Detroit for residency, and then after residency in orthopedics, I did a fellowship year. Most people don't know what that really is about, but basically it's an extra year of training. I had an interest in hip and knee replacement surgery, so I went out to California. I did a year at USC University Hospital at a joint center, so I'm fellowship trained in hip and knee replacement. And again, I've been here a little over a year and just love it, great area. Tonight's talk is on joint replacement. And I wanted to talk about things to kind of keep us healthy, nutrition, different types of arthritis, aspects of a clinic visit, those type of things. And then when it comes down to joint replacement surgery, kind of how you know when it's right to have it done, and what are the options beforehand. So those are some things I just wanted to present tonight. So the objectives again, basically talk about some treatment and different types of arthritis and kind of how we can keep our joints healthy. And I'll talk mostly about hips and knees. Again, arthritis affects other joints, of course, but tonight's topic is mostly on the hip and the knee. And then what to expect during an office visit or a consultation when you go to an orthopedic surgeon, what happens during that time. And then again, when is joint replacement surgery the right option? When we talk about arthritis in general, it basically refers to inflammation of a joint. We don't get arthritis in the middle of the bone. We don't get it in the middle of our forearm. It's always at the joints. So basically it does come down to inflammation. On the hip on the left side there, which would be the right hip, a normal joint, good-looking cartilage. And on the other side, one with arthritis where the cartilage in the joint gets worn down. There's different types of arthritis. So I want to talk a little bit about those as well. I have listed up here those types. Most of us have heard about osteoarthritis, but there is rheumatoid. There's gout, gouty arthritis, something called pseudo-gout, which is similar but different. Lupus can cause arthritis problems as well. People have that. There's different conditions, spondyloarthropathies, and then the last is actually bleeding into joints, and that can occur for different reasons. As I mentioned, the most common type of arthritis is the wear and tear arthritis. That's what happens as we get older. It's like having a car go down the road, the tires wear out at points, and you get those changed. You don't see many 70, 80, 90-year-old cars rolling down the road very often. If you do, they've usually had some work done. So a normal knee has good cartilage to it, good fluid levels. As the knee ages, it can wear out. The cartilage wears down, it gets thinner. The fluid levels change, the concentration of chemicals in the fluid change, and that also affects the rest of the joint, the lining of the knee. Rheumatoid arthritis is different than osteo. Rheumatoid is more of an autoimmune disease. And what that means is that the body actually attacks itself. So it's a condition where chemicals are released around joints, causing an inflammation of the lining of the joint, which ultimately attacks the cartilage. So that breaks down cartilage. But that's a different process than the wear and tear. Rheumatoid, there are tests for that as well, rheumatoid factor. But the condition can affect any joint, but often the hands, the ankles, the knees, and the hips, the neck. The joints are usually warm, swollen, tender, thicker, something that also affects knees, as I mentioned, and hips. Gout, another type of arthritis condition. Gout has to do with the breakdown of chemicals in foods that contain purines. Purines are found often in red meat, wine, some fish. Other foods contain purines, and our body breaks those chemicals down. In gout, the process is a little bit different. It doesn't get broken down as well, and then uric acid crystals get deposited in joints. People with gout often have an inflammation or flare-up of their big toe joint. So it's sort of the classic, is your big toe hurt you? It gets red and swollen and inflamed, so that can be a gout attack. And then again, those crystals are deposited in there, and it's very painful. It causes an inflammation. It can also affect the knee, a very common location for a gout attack. Treatment for this is usually medicine. For the acute problem, it's usually indocin, which is indomethacin. I usually think of it as like a souped up Motrin. So it's very strong, very powerful, kind of knocks down the inflammation. So indomethacin is a drug given when you have acute flare-up of gout. Other medications also help, colchicine, and then allopurinol is a medicine that sometimes people are put on to try and control the gout process to kind of keep the flare-ups from happening. So that's more of a chronic, more of a suppressive treatment for it. Pseudo-gout is somewhat similar. There are crystals that are deposited in joints, and but it's not the uric acid crystals, but it's more of a calcium crystal. On the image, there's usually a white line in between the joint, and that has to do with the calcification of the cartilage. So we see that often on a knee x-ray, that those white lines show up in there, so we think pseudo-gout or chondrocalcinosis. And the treatment for that is often supportive, anti-inflammatory meds. Ultimately, if arthritis gets bad enough, then we do talk about surgery for it. But often it's more of supportive at the time. There's a group of conditions that are called spondyloarthropathies, types of arthritis. Psoriasis can affect joints, so psoriatic arthritis. Ankylosing spondylitis has to do with arthritis of the spine where it gets very stiff. But those things do affect the hip and the knee as well. And these can be more of a genetic component, more inherited type patterns. So chromosome abnormalities, but again, they affect the spine, the back, various joints. The last one is hemorrhagic, so bleeding into joints occurs for different reasons. People with hemophilia or bleeding disorders, if they have a condition where they bleed into the joint, that's very inflammatory for it, swells up, painful. Sickle cell disease also affects joints. Blood gets in, causes the swelling and the pain. Well, just how common is arthritis? There's various studies that have looked at this over the years, but basically individuals over 65 years of age, about 50% have reported to their doctor. They go in for their routine physicals and exams and saying that they're affected by some type of arthritis somewhere. So most of us will get this as we age. It's part of the process, and then also there can be conditions like rheumatoid or other genetic issues that can cause arthritis, but very common. By 2030, estimated that about 70 million Americans will be affected by arthritis or have reported it to their physician. And I suspect there'll be more people that just deal with it and don't really report it as an issue that they have. Lifetime risks, if we live long enough, by age 85, about 1 in 2 will probably develop some type of knee symptoms from arthritis. Obesity does make a difference. 2 in 3 may develop symptomatic knee osteoarthritis, and that has to do with being overweight or heavier. It does put more stress on the joints. And then over time, 1 in 4 will report that they have a painful hip associated with arthritis. There are things that we can do and can't do. We can't control our age. We get older every day. We can't control whether we're male or female. In terms of genetics, I've often used this, we can't pick our parents, so you get what you get sometimes. The things that we can control in terms of our health and arthritis issues are our weight, of course. Diet plays a big role in this, exercise, and our life choices. Does weight make a difference? It does. There's been a study out that showed that if women who have arthritis can lose 11 pounds, and it doesn't really matter what weight they are in a sense, that it drops their risk of arthritis to the knee by about 50%. So, and it makes more of a difference if individuals are overweight or heavier. Overweight individuals do report a higher incidence of arthritis. There's something called a BMI, that's a body mass index. It's a number, and it's basically a connection between one's height and one's weight. So it does help to be taller when it comes to that. But a normal BMI is under 25, or what's considered normal. So normal individuals report lower incidence of arthritis symptoms compared to those who are heavier. Those who get heavier have a higher incidence. BMIs in the 30s and 40s, not uncommon for us to see, but it does play a role. I did want to talk briefly about nutrition. I think it's important in terms of going over a few basics, mostly talking about calcium and then vitamin D. We could probably spend days talking about nutrition, and there are nutritionists who do it much better. But calcium recommendations in general, they do vary according to how old we are, whether we're male or female. Women who are having babies, for example, need more calcium. As we age, it varies a little bit, but the daily recommendation is between 1,000 and 1,500 milligrams a day, whether that's taking it in as a food source or as a vitamin supplement. That's a rough estimate on what we need. I did list a few sources on where we can find calcium in our diet. Probably one of the best is yogurt. A plain 8-ounce low-fat has about 400 milligrams of calcium in it. And then other options, cheese, milk, orange juice, tofu, salmon, Tums also has some calcium in it. So if people are chewing on Tums for different reasons, they do get some calcium that way as well. But those are some sources of calcium in a diet. A lot of people talk about vitamin D. It is important for healthy bones and joints as well, and other parts of our body. We're talking usually about vitamin D3, and it's really not found in a lot of foods. It is found in some. The two sources, again, are mostly foods and then through sunlight. So when sunlight hits our skin, it activates the production of vitamin D in our body. So those of us that live in the North Country, we don't get out as much, especially in the winter. We don't get the sun exposure. We can have issues with vitamin D3. One can check with their regular doctor. Sometimes a test can be done for this as well, and they can check a level. But if we don't get enough sunlight, sometimes supplements, 400 to 800 international units a day. Sources are usually the oily fish. I kind of like salmon. Tuna and mackerel are listed among some of the better sources of vitamin D3. Cheeses, egg yolks, breakfast cereals, and they usually say that they're fortified, so the manufacturer puts that in there. Milk has generally been fortified probably for many, many years, and 1 cup of milk has 100 international units of vitamin D, so you could get that drinking a lot of milk, but that might not be the best thing either. It increases calories. One of the best sources, and I haven't tried this as far as I remember, is cod liver oil. So that packs a lot of D3. Some people may have been fed that as children. I guess I never was, so. But it does pack a lot of that D3. Exercise, the Federal Office of Disease Prevention and Physical Activities Guideline. There's different recommendations out there, but a general recommendation is 30 minutes a day, moderate exercise, at least 5 times a week. As we age, we're less likely to exercise with that same level of intensity, but it is still important to be moving. It's important for our joints to be moving. It keeps them going, keeps the flexibility there. And I think one of the more important things, or not more, but it's very important to maintain balance. As we age, we lose that sense of balance for different reasons, whether it's medications we're on, our balance in our ear is not as good perhaps, and falling and breaking something is something we definitely want to avoid as we age. So as we're exercising, balance is important. Yoga, stretching exercises are key, I think. And if one is starting an exercise program, whether we're young or old, I think it is helpful to start low and go slow. So I wouldn't start a running program right away. I think it's good to start off easy. The Y is a tremendous resource for exercises and programs. I swim here multiple times during the week, in the mornings or evenings. I think it's just terrific. And I think other exercises here and programs that they have to offer are really great for this community. I couldn't help, I put Arnold in there. I did bodybuilding some years ago, and I was really into that. Not that you can tell anymore, but he was at that era, Mr. Olympia, for a number of years, I think 7 in a row. And yeah, great stuff. So keep calm and exercise. As far as knee and hip arthritis goes, the numbers keep going up. Back in 97 to 04, about a 50% increase in hip replacements done in this country, over 60% increase in knee replacements. And at that time, back in 04, 500,000 knees and 250,000 hips. But generally there are more knee replacements done in this country and worldwide than there are hips. So about 2 times, 3 times as many knees as one would have a hip replacement. So it may depend a little bit on area, but there's generally usually more knees than there are hips. The numbers are going to go up. Reason for that is we're getting older, our population as a whole is aging. Also, resources available. Individuals want to do more as they're aging. I think people nowadays, they want to be outside more perhaps than they were 20, 30 years ago. And again, they want to stay active and they want to be doing things, so they're looking at options. And joint replacement has come a long way in the last couple decades. So again, those increases over 175% by the year 2030 and over 600% in knee replacements in the next years. So we see individuals in the office, we talk about things, and one of the important things that we want to do when we first meet someone is really to get a history. And that has to do with a particular problem that they have. If it's a knee problem, we do talk about how long the knee has been bothering them, the location of the pain, what prior treatment they've had. Examinations are helpful, of course. I have people walk down the hallway. I want to see what their knee does or how they walk. If they have a limp, examination on the table, range of motion. Most of the time there's stiffness, there's swelling, and sometimes angular deformities of the knee. We want to be aware of all those things. As far as the test of choice goes, X-ray is probably the king when it comes to orthopedics. There are individuals who are sent to us that have had MRIs of their joints, and we still like to get the X-ray. I think sometimes if we just had the X-ray first, that would be a big help. If we're 80 years old and get an MRI, we're bound to find something. So that's just the way it works. I've never seen a normal MRI on an 80-year-old that looks like a 20-year-old knee. It just doesn't work that way. So yeah, it'd be awesome. So the X-ray is really helpful. Sometimes if we just had that, we wouldn't have to get other studies. Lab work is helpful if people have inflammatory issues or we're thinking about gout. Serum uric acid level is helpful. Rheumatoid factor, other tests are sometimes ordered, or patients come with those already done, so that's helpful too. We do talk about treatment options. Not everyone needs a hip or knee replacement right out of the chute on the first visit. We do like to know what treatment has already been done, if they've had injections, any surgeries. A number of folks have had scopes on knees before, so those things are helpful. We do talk about weight loss, medication, arthritis pills, injections, and I'll kind of go over this in a moment or so. Therapy, whether they've been on pain pills. Narcotic medication is not a mainstay. It's not something we like to use long term. I have used pain pills or narcotics just for short-term use in extreme cases, but it's not something I like to do routinely. Usually it's more of the anti-inflammatory arthritis meds that are going to be the treatment, and then maybe ultimately a surgery, but narcotics is usually not the best choice. When it comes to the American Academy of Orthopedic Surgery recommendations, the top 3 really are, again, exercise consistent with guidelines. So staying active is important. Weight loss, they do endorse or recommend weight loss if people are overweight. And then they also recommend the use of anti-inflammatory meds. And that's something we can buy over the counter. Something such as ibuprofen, which is Advil or Motrin, and then Aleve, which is more of a naproxen product. So in terms of the American Academy goes, those are the top ones. Okay, the question is, what about Tylenol for arthritis? And I found that Motrin, the ibuprofen, generally works better. Aleve is longer acting. So, but it is helpful to check with your regular doctor to see if it's okay to be on those medicines, even though they're the over-the-counter medicines. Sometimes they don't want you to take them because it may interfere with other conditions or other medications. So that's important to check with them first. But ultimately, if there is no other option, then sometimes, yes, certainly Tylenol can be helpful. And I wanted to bring up the lubricant shot. I call it lubrication shots, or the lubricant shots for the knee. Some people come in and ask for the chicken shots. So, and most people have heard of these. And then the question is, well, what is it? It is basically an injection. It's not a steroid, but it's more of a gel. It's a form of hyaluronic acid, which we normally have in our joint fluid. And it was approved by the FDA in '97. It's approved for knee injections. There are different brands or companies out there, and they make Synvisc, Supartz, Hyalgan, Euflexa, and there's others. So those are names of the different types. They basically originally came from the back of a rooster comb. And again, that's the red part on the top of the head there. So I put the rooster up there in case we forgot our rooster parts. And how they exactly came up with that, I don't know. But someone in a lab figured out that they can derive this from the back of a rooster comb. So there's a lot of roosters without their comb. There are a couple that are fermented from bacteria, so those are derived in a lab. And then how do they work? Again, people with osteoarthritis in the knee, the fluid concentration of hyaluronic acid in the knee is not normal anymore. It does change. And then it's felt that by putting the shot in, it's more of a gel, that it gets in there. It increases the concentration, but they've looked at it. It doesn't actually stay around a long time, so it doesn't stick in there. I mean, we do talk to folks that it can help contour or smooth a little bit, but it's felt that it actually may rebalance the fluid in the knee joint to kind of reestablish it to a more normal, therefore allowing things to settle down. So those shots are usually given in a series of shots, anywhere from 3 to 5, or there is a company that makes a one-time shot that you put in. If the shots help, you can hopefully repeat them in about 6 months. So it's not something we do every month or two. And they are spendy. So some of the shots require insurance approval before we just give them. Not all of them, but some of them do. So, but they do get pricey. So I've seen, I put the shots in. For some folks, they do seem to help. Others mention that they just don't help that much. And again, I think most of these treatment options will help more if the arthritis is not as bad. If you're already bone on bone, they don't seem to help as much. Do they work? There are studies that have looked at that. There are studies that show that there's no help or mild to moderate help. And again, the Academy recommendations, they've looked at the studies as well, and they basically said that they can't recommend the use of those injections for patients with OA. Although, again, they are available and we still do them. But this is coming from the American Academy of Orthopedic Surgery. So again, they looked at all the treatment options out there. Again, exercise, diet, and over-the-counters are their recommendations. The other ones, acupuncture and other treatments, they looked at studies and they say we just can't, based on the study review, recommend those as a mainstay treatment. Glucosamine and chondroitin, these are pills we can buy in the store, just off the shelf, sort of the vitamin for the joint. There's different studies also that look at those, a Gates study and a New England Journal of Medicine study. And they've compared glucosamine to chondroitin together versus Celebrex and placebos. What are the outcomes on those? And again, the Academy recommendations, they've looked at all the studies and they felt that there were minimum clinically important outcomes have been achieved compared to placebo, whether evaluated alone or in combination. So I'm just trying to give you information according to the Academy. People ask, well, is it helpful? I tried them myself for a period of time years ago, so didn't felt that it made a huge difference for me. I just stopped taking them, and I take some over the counters. That's just me. So others have taken these and feel they do help. So that's been others' experience with it. The office visit, again, I mentioned, centers around x-rays. These are x-rays of a knee, and basically people come into the office when symptoms are bad enough. If people had no pain, they wouldn't be coming in. So when it bothers, they come in and we get x-rays, or if they haven't already been done. A normal knee, for example, will have space on the x-ray. That's a good thing to have. When the space goes away, that's not good, and that's more of a bone on bone. And that's when things start hurting more. There's more pressure on the underlying bone. Again, the inflammation of the lining of the joint and the tissues around it all have nerve endings in it, and things start to hurt more. Interestingly enough, cartilage itself does not have nerve in it, so there's no nerve endings in articular cartilage. And there's no blood vessels that feed it either, so it gets its nutrition through another source, more diffusion, but and then without the nerves in it, it's really more the surrounding tissues and the underlying bone that feels it when you get arthritis, because there's more pressure changes to the bone. So we talk about surgery options at some point. Again, we've talked about other treatment plans or what may have happened in the past and what we can do moving forward. For the knee, it comes down to, will a scope help? And that's an arthroscopy. We don't routinely scope knees just for arthritis issues. It will help at times if there's an associated cartilage tear, but if it's already bone on bone, just going in and trying to clean that out is not going to paste any cartilage back in there. So when we pull a scope out, if it was bone on bone going in, it's going to be that way coming out, and you'll likely still have symptoms. Scopes usually help better if a knee, for example, has a torn meniscus in a younger person with mild or minimal arthritis issues. That's when it usually helps more. Partial versus total knee replacement, I have some other slides to go over on that. And then hip surgery, hip arthroscopy is also being done. Again, that usually works better for individuals that have torn soft tissue around the hip joint without significant arthritis problems. And then hip replacement surgery. On this particular slide here, there's a normal space on the outside of the knee, and then standing x-ray, there's a bone-on-bone contact on the inside of the knee. This is actually a partial knee replacement x-ray, and partial knee replacements are done when the arthritis to the knee is primarily on the inside of the knee joint, that inner half. There are some other criteria in terms of range of motion or flexibility and other findings, especially from the office. But this is what a partial knee replacement looks like from the front. Metal parts with a liner in between, and then the slide on the right-hand side is a partial, and then a total knee replacement is the furthest one on the right. A total knee is when the entire surface area is changed out. So again, it's mostly resurfacing the end of the bone, putting a metal cap on it, and that's the thigh bone. Same thing on the shin bone, that gets leveled off. So it's cut straight across, a metal cap, and then the white part is the plastic liner in between the two, and that becomes the new surface. So partial versus total knee. And then these are just representations of what the parts look like. You can see the bigger parts, if you will, for the total, with the thigh part, the shin, and then the liner in between, and then the partial on the right, which is just the one half of the knee. Hip replacements. This gentleman is Dr. Charnley. He is pretty much considered the father of modern day hip replacement surgery. He was British. He pioneered many of the advances at the time over the years in the early 40s, 50s. He worked on how to fix the part into the bone. He worked on the bearing surfaces and an x-ray of one of his earlier replacements. So at that time, the part was cemented in, and then the same thing with a cup. But that's he was a pioneer for joint replacement surgery over the years, and from there it took off. But he was the fellow that started it. Hip replacement. The slide on the right-hand side is a severely arthritic hip with bone on bone. The X-ray on the right shows the replacement, and again, there's a stem that goes into the leg bone, which is hollow, so we can put things in it. There's different ways of fixing it or holding it. There's a new ball, and usually a liner and a new cup gets put into the hip socket. So again, the arthritic portion of the hip is removed. It's replaced with a new bearing surface, and there are options on that as well. People ask about approaches to a hip replacement. There have been various ways to get into a hip. It hasn't changed much, but some have come forward more in the last years. And there's an anterior approach, a side or a lateral, and then also a posterior approach to the hip. And that's just a means of working one's way into it to get the parts in. I wanted to go over briefly approaches. An anterior approach is thought to be more muscle sparing. It's more going between tissues as opposed to cutting or releasing. There are times, even with that approach, that it may be necessary to release some tissue or to cut for better exposure. It's usually easier to do that on a thinner person as opposed to a heavier person. There is special equipment that's needed for most anterior approaches, special operating room tables. They're probably about $250,000, I think. The dislocation rates, they're still there, and it's not zero, but anywhere from 0.5% to 1.5% to 2%. If they're going to dislocate on a front approach, they usually come out the front at some point because that's the way they go in. They tend to dislocate that direction. They generally also have a higher fracture rate in terms of breaking something, either putting parts in or during that process. The table is attached to the leg. There's traction pulled, maneuvers to get exposure, so there can be a higher fracture risk with this. Nerve injury refers to one of the nerves over the front of the hip and thigh that can be stretched or injured during that approach, and it's been reported anywhere from 15 to 80%. That can leave some numbness or some pain, discomfort in that course of that nerve. Side approach, again, it's more of a muscle splitting, but there is some detachment of muscle on that as well. There can be a limp with that, fracture risks, and nerve injury as well, different nerve depending on how far they split the muscle. Posterior approach is still the most common. Dislocation risk still 1 to 3%. Mine has been less than 1% in practice, so I feel good with that. It's not zero. Things do happen. Fracture risks are generally lower, and nerve injury, if there is a nerve injury, it's most commonly the sciatic nerve, which runs around the back of the hip. I haven't personally experienced that, but if you get into it, it could be a cause for nerve injury there. But it's a low risk on it. I was trained in a posterior approach. That's how I grew up. So I did my fellowship out, as I mentioned, at USC. Gentleman I trained with had done them that way for many years, and that's how I was trained, and that's how I trained in residency as well. I saw side approaches at various centers. Columbus, Ohio, Joint Implant Surgeons. I went there for a number of months. They did a side approach. I thought it was interesting, but the disadvantage to that can be people have a limp because you have to release some of the tissue on the side of the hip, and it's sewn back, but if for some reason it doesn't reattach well, I mean, they can limp because that's the tissue that keeps your pelvis stable. Front approaches, I just didn't have at that time the exposure to it. It wasn't as common back then, so I've generally stuck with a posterior approach. It works well for me. So. In any event, in terms of what approach to use, the goal with it for hips and for any joint replacement surgery is to minimize risk. I think much of it has to do with, in a sense, where you have the surgery done, who does it, how long they've been doing it. All those things are important. We want to maximize results. Obviously, patients want to do well. We want them to do well. Recovery time, there is recovery with joint replacement surgery, usually a couple days in the hospital. There are centers around the country that are trying to get this number down, get people out quicker, different ways to do that, and in part it has to do with pain management. I still have a hard time sending someone home in a day or two that have just had a knee or hip replacement. Just don't feel terribly comfortable with it at this point still, but we're trying to work on that and get those times down so they just spend less time in the hospital and are still comfortable and can manage whether they go home or they go to a care center. We want the parts to last. longevity. People ask how long will the part last. I usually say at least 15, 20 years, that's the goal. They can last longer, they could last shorter, but on average, and people should be able to have this part in for the rest of their lives ideally. And we do want people to return to a normal life. So in conclusion, again, there are different types of arthritis. Osteoarthritis is the most common. Exercise and nutrition, lifestyle, those are all choices we have that can help make our joints last longer. There are options. Again, a lot of that can be detailed out in the office visit, and to come up with a plan is for a good treatment option. When we consider hip and knee replacement, when is the time to have it done? I usually tell patients, usually you come in and have it done when it bothers you enough and it interferes with your lifestyle enough. Some people don't have that much pain with their joint, but it does interfere with their lifestyle. They can't do things they want to do, there's stiffness, soreness still, and those are things to consider. So we do try and help with that decision making, but ultimately it's the patient's decision. Again, basically it's pain and function. And it does start with an office visit. We'd be happy to see patients, and whether they see their primary care provider first or they come to us, the goal is to get people back to doing what they want to do and try and do it as safely as we can with minimal risks for them. Thank you very much.